I got it. It should be recording. It should tell me that it's recording. You need to give me a, yeah. Okay. It should be recording. Yes, here it is. Yeah. Okay, good. Very good. Okay, guys, let me just share my screen. What I'm not going in depth in things. I know what is on the test, and I want you guys to have an understanding of what is on the test. So let me share. Let me just go to my PowerPoint here. I'm sorry. Yeah. So that is it. So what I do, I made sure to put things that is I know that you need to know. So if you see it there, you need to know it. That's only thing I'm telling you. So it's important that you know it. Like you're gonna see something related to that on the test. Okay. So I'm just wanted to let you know that. So, and I'll emphasize it also when I'm talking. I'll emphasize it also. So let me share my screen. I have a lot of PowerPoints open because I have to do the juniors in the next hour also. So, okay, I want to make sure you get everything in here. I'm sharing my screen. Okay, good. Let me get this. Are you seeing my screen?
Yes.
The one that says valve, veins and valves. You see that, or something like that? Intravenous therapy. Are you seeing that now?
Yes.
Okay, good.
Is this posted in our modules?
No. This is I made this. I made this for this.
Thank you.
Is that okay? But if you want it, I can
have the slides.
Yeah, I think I should. Modules. I probably should post it. It's not in the module, but I probably would post it somewhere for you. Okay, so here we're talking about intravenous fluids, IV. What your test has is mostly. Somebody wants to come in. Sorry, I have to admit the students in. So, right. So after this presentation, you're going to be able to do this. Identify types of IV access lines. Identify types of intravenous infusions. The IV sites, the equipment, the nursing management, and you're going to adverse effects and complications. And those things are in your test. Okay, so we have types of access. We have peripherally inserted venous access. We have midline. You have the PICC line also. And the PICC line is also a peripherally inserted central catheter. And you have non-tunneled central catheter, and you have tunneled ones. So, and I'm going to explain them later. You'll see that. Okay, I didn't add any title here. Central inserted catheter. You'll see some of them is non-tunnel. Oh, should make it a little bigger here so you can see it here. Sorry, a little bit bigger. Okay. Okay, so here you can see a centrally inserted catheter. You have non-tunnel and you have the tunneled one. And here you see it's a reason for it to get short-term care and typically used for several days. Usually you may see that it's really easy to use. However, it's used for several days. And the reason why it's used for several days is because of infection. And certain medications can create a forum or for infection. So the doctors don't like for it to stay in a long time, but it can stay in for a long time. But they don't do that because of infection. It can grow microbes real fast. Certain medications, especially like TPN and all that, it's an area where you can get a lot of problems from it. So the doctors don't like to keep it in for a long time unless it needs to be there. And one of the non-tunneled is like PICC lines. You see a PICC line is really a non-tunneled, and you have the tunneled ones where for long-term therapy for patients who are getting chemo and all that. So you'll see that. Here, and you see the sites. You see sites for the central lines. You have the subclavian. You have the jugular. You have internal jugular, and sometimes you have external jugular. And then you have the subclavian right here in the chest, upper chest. You have the PICC line here in the arm, and then you have the femoral. The femoral ones used to be real popular, but they don't do that much anymore unless it's an emergency because of infection, because it's close to your pubic area and all that. And some people, they don't have the time to take care of it when they're ill. and all that, so they don't usually do that. But in an emergency, it's the easiest place to get an IV in an emergency. So the femoral area, easiest place. There's no ifs, ands, or buts. Once you hit it, you'll get it. It's not like the subclavian and the jugular. It's really hard, so they don't, but they don't do it very often. Okay, for the advantages of central venous therapy, this is important. You see here the advantages. A central venous catheter differs from an IV catheter that is placed in the arm, in the hand or the arm or your forearm. And a central line is, as I say, is longer with a larger tube and is placed in the large central vein in the neck, upper chest, or the groin. And it's used when the patient needs large amount of fluids in a short time, when you want blood specimens to be collected easily. It is used for a longer periods of time than the IV, because you have to change your IV every 3 days. And it's preferred method to infuse medications that may damage the peripheral veins. You know, like when you're given potassium, it's not, when you're given potassium is caustic, although we give it IV in the regular peripheral IV. But if you're giving someone potassium and you want to run it, especially if an older person and they have a central line, it's best to put it in the central line. If that person, vancomycin is one of those medications also cause problems with the vein. If you have, by any chance you have a patient has one, you can give them, use it for that. But those medication will cause problems for the patient. So that is something you need to remember. Types of infusions, we have the primary, secondary, and IV. So as you can see, the secondary, the IV piggyback, you guys know this, and you can see it's going to be on your test, so you can see how it's done. Okay. And where the most common IV sites, as I said, the peripheral, and you see how it's done here. You can make sure it's usually in the forearm, and the most common place that people, nurses would like to apply a peripheral IV is in the AC, antecubital. However, it's not good for the patients, and you'll see why it's not good for the patient when we go further down. But you can see it's in the forearm, but nurses like to put it there because it's easier for them, and but it's not easy for the patient because it's every time if they have a pump, if it beeps, if they bend the arm, it beeps, and the patient, it's noisy, and the patient, they can get upset and all that. Especially if it's an older person, they get confused, they don't know what's going on. So you have to be careful when we have IVs sites there. Okay. Common IV sites for children and infants or toddlers and all that. That's an important one. The appropriate sites for IV infusion in neonates include the scalp, the hands, feet, and the forearms. And it's important that we remember that part. The scalp is the #1 place we do IVs for neonates. And children 6 months and less, that's where we do IVs for them, usually the scalp. They're going away from it now, but it may, they're still using it, but the scalp is where they're doing it. But that's where we should focus on. Okay. Locations, the IV locations, we talk about that. The AC is usually the AC is usually the area where sorry, someone is saying something? Okay. Is where, especially in the ER, everybody likes to use it because for the ER, the nurses want to move fast. They don't have the time to be looking around. They just want to put IV in. So they use AC, which is not really good for patients on the floor because they're running, the IV is running, and and you're getting beeping and beeping if the patient bends their arm because they forget that they need to pull their arm out. When you're doing an IV, you need to remember the gauge is important. Small gauges sometimes will cause chemical burns, and we're going to go into that. I should have put that before, the chemicals. Small catheter, they usually allow for more blood flow though around the catheter because it's not large. And when you have a small catheter like a number 22, which is the smallest, we use usually in adults, number 22. And it's easier for the medication and all that to flow. It's not blocking up the vein like a huge catheter, like a 16 or a 14. The large catheter is painful during insertion. So for you and as a nurse, the biggest you'll always put in is a 8, is a 6, a 20 when you're on a regular floor. If you're in the ER, or the doctor orders he needs an 18, then that's it. But usually you want to put in a number 20. You don't want to put an 18 or a 16. You can't put a 16 in anyway. Nobody can stand 16 on a regular IV insertion. You can't do that. A 20 or a 22, you don't normally put in for a patient. And then sometimes you end up with phlebitis, and I'm going to, it's down in the other areas. You see phlebitis. We'll talk about phlebitis. So here on the forearm, you see these areas. The cephalic, you see how the arm is? This is AC area, but you see the cephalic vein right here, and you see the accessory cephalic vein right below there, branching off from that. And then we have the median cubital vein branching off from right there. And then you have the basalic vein. Usually they use this to go up when you're doing the most common one for PICC line is the cephalic vein. They use that a lot, are the basalic one. Okay, these are the gauges for your, and it's important that you know the gauges. You have the blue, which is a 22 and all that, you know the colors, the pink, which is a 20, the green, which is 18. Usually if you're on a regular floor, 18, 20, or 22 you'll use, but the doctor usually orders for you to put an 18 in. If the patient is going for a scan and he needs dye and all that, they will always want to do that. But for you, usually don't put a 16 or a 14 in, you don't do that. And an IV usually lasts from 72 to 96 hours on a regular floor. And that is, you need to remember that also. Commonly used IV catheter. These are the colors, as you can see, 20, 18, 22, and 24. 24 is used, especially if the patient has is an older person, or the patient has has cancer and they have bad veins, and they usually, it's hard for you to find a vein. You use a 24 is used, or in a child they use a 24, but the others are used on regular adults. Okay, this is important also. You need to know the steps that you use to insert an IV. So, you know, when you put the IV in, you put the IV in, and then you know what do you do after that. And they're going to ask you, what do you do after that? And what do you do after that? And what do you do after that? So here, they want to find out, you put the IV, you insert the IV, the needle, then what do? You thread the catheter forward, and then you pull back on the needle. And the needle, they call it a needle case, that house the needle, you pull back on that. You hear the click, you turn the needle case housing quarter inch or so to the left or the right, and you remove the needle case housing. That is one of the things that you should know. It's very important that you know that. Okay. Okay. Veins and valves. You know, we have veins, and in the veins we have valves, and that is important also. It's in your, so it's important that you know that. Valves are inside the veins, and they keep the blood flowing toward your heart and prevent it from going backwards. So, the backflow, we call it. So when your veins are weak, the valves get damaged and allow blood to back up and all that. So vein valves are a major part of your circulatory system. You know that. I don't have to explain that for you. You know that. Vein valves work hard against gravity to bring the blood that flow down in the arteries. And they're usually easily seen, and you can palpate them. That is important. So one of the things you should be listening to. So you want to make sure it's palpable, you can palpate it. What is phlebitis? It's important that you know what phlebitis is. And what is phlebitis? Is the inflammation of a vein. And there are 4 kinds of phlebitis. You have the mechanical phlebitis, you have the chemical phlebitis, you have infective phlebitis, and you also have the the post-infusion phlebitis. So you have 4 phlebitis there, and the information on your paper going to ask you about phlebitis. So you need to know the mechanical one occurs where the movement of a foreign object. So when you put the IV in, and the IV comes out of the vein, it causes friction. That is what they call a mechanical phlebitis, and it's common in the AC area because the IVs all usually slip out when because the patient's moving the arm up and down all the time. So that is what the chemical phlebitis now, a little self-explanatory, when they caused by the drug or the fluid that infused through the cannula. So the pH or the osmolarity of the substance will affect the area and cause it to the inflammation there. Then you have bacteria or the infective one. When the bacteria penetrates the vein, that usually especially when you don't clean the site properly, that will happen, and it causes the patient to have systemic sepsis. That will happen. And then the post-infusion usually comes after 48 to 96 hours after you remove the catheter. Sometimes you'll see a little redness there at first, but then after that you'll see it get real bad. So it's important for you to know that. And then here also, antibiotics are reported to increase incidence of chemical phlebitis, and that is also important. And the infective phlebitis is caused by, we know, introduction of the bacteria is there. Okay. Okay, and then we're talking about isotonic fluids here, and okay, isotonic fluids have been found to lower rates of phlebitis, but hypertonic fluids increase the incidence of phlebitis by initiating the inflammatory response, and that's also important. TPN, patients with TPN is hypotonic, but this osmolarity can be adjusted because sometimes they decrease the osmolarity of the TPN to prevent the patient from having problems, because it does, as I said before, it does cause problems to the patient. That is why that's why most times now they use central lines and the tunnel ones, because patients, you can start a TPN with a peripheral line, but you cannot continue for just for a couple hours, and the doctor has to order a central line or a PICC line, because the patient shouldn't have a peripheral IV for using TPN. But sometimes, and they call it PPN if it's a PICC line or a peripheral IV, they call it PPN instead of TPN when the patient is getting it. Okay. And the nursing management, as you can see, when you're doing an IV, you need to have your equipments, and I know that you know your equipments. You know the equipment that you're going to use for the IV. What equipment do you need for IV? Anybody know?
Need starter kit.
Okay.
Extension
Come on, guys.
tubing,
Huh?
extension tubing in your autoclave.
Okay, good.
Tourniquet, gloves.
Okay. Gloves. Mm-hmm.
Tegader.
Okay, good. Okay, so if you have a patient and you have a patient and you're giving the patient your IV fluids, and the IV fluid is running fast, what would you monitor the patient for? What are the number one signs and symptoms would you monitor the patient for?
Tenderness, redness,
Tenderness, redness.
swelling,
Okay.
burning,
Mm-hmm. Anything else?
the string like
Blanching.
Blanching. So if the patient is getting the fluid, you're running the fluid at 200 mL an hour. Do you think anything can happen to the patient? Anything?
Overhydration,
Huh?
pulmonary
fluid
edema.
overload.
I said fluid overload.
Fluid overload. What do you say, Steve? Steve?
I said pulmonary edema, so we'd be checking for crackles in the lungs. We'd be looking
Yes.
for edema.
Yes, that's important. You'll be looking for that. You'll be looking for that. Pulmonary edema. Very good. So you want to make sure you monitor your patient for that. Okay, very good. Do you know, have you, I'm sure you guys have been taught this about giving medication via IV. And do you know how long does it take for the IV, the medication that they give a patient? When you're giving a patient medication in an IV, especially IV push, or what, or any or IV from the forearm to the heart, how long does it take? How long does it take to reach the heart? Huh?
Instant, right?
Sorry?
Immediately? Instant?
Oh yeah, yeah. I like that word immediately, but you know, as nurses, we don't go with words like that. We have to
Would it
use
be like 5-10 minutes?
seconds, minutes, 5 minutes. Huh?
I just said like 5 minutes.
5 minutes. Okay. Anybody else have a number? Come on, guys. Nobody answered me. I'm gonna put 2 more questions like that there. Then okay.
To reach the heart, it should only take 30 seconds or.
Okay, 30 seconds. Okay. Well, you guys need to figure it out because yes, you need to know how long it takes the IV fluids from the IV forearm, from the forearm to your heart. And then Steve is on the right track. Okay, very good.
I don't think anyone has told us that before. Would you mind telling us how long it takes?
It doesn't. Nobody have told you that before?
I don't think so. None of us know it.
Oh,
Isn't
come on.
it five
Taylor.
liters a minute? Doesn't the heart pump 5 liters in a minute? And
Yes,
six-
5 liters in a minute. It should only take the heart. It should only take us 15 seconds to get there. 15 seconds.
Oh,
Yes.
I was gonna say 15 seconds.
Oh yeah. Oh, good.
I
That's
was gonna
good.
guess that.
Huh? Huh? Yes, 15 seconds it takes you. Okay, and that's good. It's 15 seconds it should take you. Okay. Alrighty. So here we are. We have when you have complications from inserted the IVs. This is what your hand looks like: the pain, infection, and blood clots, and the air embolus. We can get that complications from that. IV fluids. It's important that you know the IV fluids, and these are the ones I put there, and these are the ones it's important that you know. We have isotonic, hypotonic, and hypertonic, and there's information about that. So it's important that you know these fluids. Yeah. So central venous catheters, right? As I said before, they carry risk, although they're centrally administered. They do carry risk. Nurses and doctors like them because you can do certain things with them. Sorry, let me just close this door. I'm sorry, dear. Sorry about that. Okay, so when you have a patient who has a central line, it has a major risk to the patient. What do you think is a major risk to the patient when they have central line?
Infection of the heart.
Infection, very good. Infection. Infection. We all use it. We all use them all the time well, not you guys, because you guys don't have the chance to use them yet. But as nurses, we use them and they cause a lot of risk, especially infection. You'll be surprised to know, because if you don't clean them properly, infection is so easily given through that. And just like that is the reason why TPN is so important. When you have it, you have to make sure you change the tubing, because it's a medium for infection, because it has so much glucose in the bag, and you know, they like the glucose, the bacteria and all the microbes and all that. So we have to be careful. Yes, it's a medium for that. So be careful. That's one of the an area for infection. So when you're doing central line, be careful. You usually get infection from that. So your patient need to okay. What about blood? You guys learn about blood already, right? Right?
Yeah,
I'm wondering.
blood transfusion.
Blood transfusion, yes. Blood transfusion. So when you're giving blood transfusion, what blood is the most commonly given blood?
O positive.
No, not the. I'm sorry, not the group.
Packed red blood cells.
Yes, packed red blood cells, the most commonly used blood product. So when you're giving and what do you use when you're hanging blood? What do you use to hang it? What kind of fluid do you put it up with? What kind of fluid do you use to hang it with? Right now, some places are not using fluids, but if you should be using fluid, what fluid do you think you should hang it with?
Normal saline.
Normal saline, very good. Normal saline. Okay, so if you are hanging the blood, hear me. You're hanging your blood, and you send your patient have a number 20 gauge IV. Listen carefully. Your patient have a 20 gauge IV, and you said you just went in and you flush it and it's working fine, and you sent the tech down to pick up the blood, and she went and picked the blood up, and she came back with the blood, and you're going to hang the blood now. But when you went in to hang the blood, the patient said, "Nurse, my IV fell out," and you have to hang the blood there in your hand. What do you do? Is how many hours do you have before you can hang that blood to start to get an IV?
30 minutes.
How many?
30 minutes.
30 minutes.
Mhm.
Okay. Kiyomi, you said 30 minutes.
No, that
Kiyomi?
wasn't me. But I didn't know the specific number, but I knew you didn't have long before the blood starts clotting. So, but I didn't
think
know the
it's
specific
2 hours.
No,
number.
it's not gonna. It's
I
not
think
gonna
it's-
clot. It's not gonna clot because it has it has some hours to go. So you have how many hours do you have? Because remember, she brought it from the blood bank to you, and you don't have an IV. So you want to put an IV in. So how long do you think you have to put the IV in before you either return the blood to the blood bank or you have to throw the blood out?
2 hours.
Yeah, about that 2 to 4 hours you have. 2 to 4 hours. So you want to make sure that's one of the things you need to have. One of the things you need to remember, you have 2 to 4 hours to wait before the blood is no longer good. Okay. Alrighty. So when you're giving blood, what medication would your doctor order before you give blood, after you give blood, or in between the blood? Before, after, or in between? What medication you think that would order for any patient you're giving blood to?
I'm gonna go with Benadryl, but I don't know.
Benadryl. Okay. All right. Benadryl. That's what you say. Who said Benadryl?
Kayla.
Kayla. Okay. Anybody else support Kayla?
Lexis.
And what you said?
Lexis. Fusamide.
What did you say?
Fusamide.
Saying LASIK.
Furosemide. Yes, furosemide. You want to give furosemide. Yes. You want to give it before, in between, or after. The doctor may order it. Usually the doctor orders it, but usually you, the nurse, can say to the doctor, if I'm giving Mr. Jones 2 units of blood, I would want him, Dr. Jones would like to order a unit, 10 milligrams or 20 milligrams of Lasix. It's important, and you tell him why. Because when you give blood to the patient, what happens to the blood cells? What's your name again? Tommy, if you're giving the patient the blood, what happened to the cells?
Yeah. I think hemolysis happens when I give blood.
Hemolysis happens?
Yeah, like there's yeah, the red blood cells break down. Yeah.
What are you saying? Anybody else can help him?
It would become more like thick and viscous, probably.
Okay.
So-
Anything else?
It would help the heart. The Lasix would.
Okay. What else? Anybody else?
Lasix make it thicker though? Like getting rid of the water?
What did you say, Taylor?
I said, wouldn't Lasix make the blood thicker though? Like getting rid of the
Lasix?
water and
No,
stuff?
Lasix, you think would make it thicker?
Because you're getting rid of the water in the blood, right?
No, you're not getting rid of the water.
Oh,
but
I want to get rid of potassium because the blood cells don't break down of blood cells cause potassium to increase.
Yes, so what happens there to the patient if you don't give them the Lasix?
They'll
Hyperkalemia.
become hyperkalemic and they'll go into metabolic acidosis.
Okay, what else? Come on, guys. When you give the patient the blood, what happens to the patient? It increases
Their hematocrit and their
the
The osmolarity increases, so you're going to get more fluid going into the vasculature.
yeah, and the patient gets what?
So you become fluid overload.
Fluid overload. Thank you. The patient becomes fluid overload. So you have to, yeah, that's why you give it to them. The blood does that to them. So when patient is getting blood, if you have a patient who's getting blood, you have to remember that, because sometimes the doctors are rushing. They don't remember. These 3 medications they order: Lasix, Benadryl, and what again?
normal saline.
No, Tylenol. Usually, because if they don't order it, you the nurse, when you're critically thinking, you let them know, because sometimes the patient, if you give them Tylenol, it protect them from getting a temperature when it's not really, it's not really, because some patients get a temperature. It's not really that they're reacting to the blood, but some people will stop it. The patient needed blood, so just give them the Tylenol. Patient need the patient may get an itching or something because of the blood. That doesn't matter. It doesn't mean that he's reacting to the blood. You give him Benadryl to protect him from that, and then the Lasix protect him from the fluid overload. So remember that. Yeah.
Do they all get Lasix, or is it
No,
just?
they don't. No, they don't all get Lasix. Like someone like you, Taylor, they may not give it to you unless you're getting 2 and 3 units at one time.
So it's only if they're experiencing symptoms of fluid overload that
No,
you give.
not if they're experiencing symptoms. The age have a lot to do with it and the diagnosis.
Okay.
The
But what
age
if
and the
they're like
diagnosis.
bleeding and they like need that blood? You wouldn't give them Lasix, right?
If you're what?
If they're bleeding, like they're hypovolemic, you wouldn't want to give.
No, you're not gonna. Yeah, no, you're not.
Okay.
Unless they're getting a lot. If they're young and no, unless they're getting a lot of fluid, and you're checking their labs and see if they're going into issues, you can probably give it to them. But if they don't need it, especially if you're young, but if you have any cardiac issues, yeah, that's a must. If you have cardiac issues, and it's gonna make your heart work harder, or if you're older in the older age group. If you're young and you're getting a lot and you're not bleeding, yes, they still have to give that to you too. So you'll see that it depends on your patient, the complaint, and especially the chief complaint that they're having. If you're bleeding, they're not going to give them unless they're having many units of blood.
Did you say why we give them Tylenol? Can you say it
The
again?
Tylenol is the temperature. Because when you get blood, most people who get blood, the temperature increase. However, it's not that you're reacting to the blood, but the temperature goes up because it's somebody else's blood, right? And sometimes antibodies, depends on the antibodies that are there. If it's a problem with antibodies, then you'll know because the temperature will still go up higher if even when you still get when you get the Tylenol. These are the things that is very important that you know, even when you're now, for example, when you're practicing, because usually there's not some people there to tell you these things, and you'll stop the blood because you see the patient has a temperature, and it doesn't need to be stopped. So you can research that more when you're working on a floor and see how it works. It's not because the patient react to a problem with the blood when you do that, because you just want to make sure. Some doctors just give it to you, especially the doctors who are experienced. They just say, make sure you give those things before, because I don't want you calling me, because especially as a new nurse, she may call in because of that, and it's really not necessary. But you'll see when you start working, because people, individual, you'll see. Because when you're working and taking care of patients, it's not a book. They are individuals and things that would happen to them. Okay, so what about dosage calculations? You guys are good at dosage calculations, so I don't have to worry about that. But when you're going to do, make sure you look up. I want you to go through your heparin calculations. I want you to do that. And when you get exams for dosage calculation, you're not to write. It's on your exam paper anyway, but you're not to write the measurement or the unit. Don't write that. If you get a number that says 0.25 ml, don't write 0.25 ml. You write 0.25, and that's it. Nothing more. Remember that. And the reason for that, if you write that, it's going to, sometimes what it does, if you write ml, sometimes it changes, it jumps here. If you're on number 27, and you click it, it will jump over to number 29, and you don't get a chance to answer number 28. It does that sometimes, so make sure you just write only the numbers and not the units. It's on your. It's also the instructions is also there. So please read the instructions. You don't do that. Just only write the numbers and not the units. Okay, and you're gonna make sure you remember micrograms per kilograms per minute. It's gonna be on there too. You only get about probably about three or four dosage calculation. Let me see. When you're doing dosage calculations, and the nurse said she starts the IV fluid at it hung at 2 o'clock. She hung it at 2 o'clock, and it should end at 10 o'clock. Do you count the hour? Do you count 2 o'clock in it, or do you count 10 o'clock in it? The time it starts and the time it ends. You know, like I said, okay,
No.
I arrived at 2 o'clock. Huh?
We start counting from 3.
You start counting from 3. Okay. Everybody agree? Everyone agrees? Okay, good. So you start counting at 3. Okay. What about drug labels? You had it some years of, not some years, I'm sorry. You had it a couple
Wait,
months
just one
ago.
thing to clarify, we started 3 and we include 10, right?
Yes.
Okay, I just wanted to clarify that.
10.
So it's basically 8 minus 2.
Yes, so if you
whatever.
started, just say if you started.
Whatever, 10 minus 2. Okay.
Yes. Okay, and dosage, you're not getting a lot of dosage calculation. I think about 4 or 5 of them you got. So 4 or 5, yeah.
Do we have to get a 90 on the dosage calc? Is that how you're grading it?
90. Did they say that?
Well, I know. I'm just wondering, is it part of the IV test, or are we having like a separate dosage calc test?
No, the dosage calculation. No, the dosage calculation. No, it's the same thing. It's the same. You have 35 questions, and the dosage calculation is involved in it. And you have
Okay,
one.
so it's part of the IV fluid test. Okay.
6.
Okay.
It's a part of the IV. Yeah, it's not a different. It's the same thing. And it's only 6 questions you get for dosage calculations. And as I said to you, I'm telling you, you have the micrograms per kilograms per minute, and you have the heparin, and then you have the read the label. There's a read the label thing on it too. I remember vancomycin, I'm not sure if I told you, vancomycin is caustic to the vein. So when you're giving it, you have to be careful. What are the advantages of using a central venous line? What are the advantages? Give me one, Alexis. You have a central line. What are the advantages of using it?
It's fast acting, whatever you inject into it.
Okay.
It lasts longer.
Ada. Yes. Okay. Ada. Who said last longer? What? Kayla. Okay. Last. It's not that it lasts longer. It's have a longer time. Yeah. It stays in there longer. Okay. All right.
Yeah,
Good.
but you
That's
can
a
go
good
home
one.
with that stuff. So I would assume you can
I'm
go home
what-
with that stuff. So
I'm sorry.
you can go home with a central line.
Oh yeah, you can go with the central line.
So
Yes.
I just
Yeah,
figured
depends on where it's. Not
that's
all
definitely
central lines you
longer
can go home
than a
with.
peripheral.
Huh?
That's definitely longer than a peripheral.
Yeah, you have remember also too that a PIC line is a peripheral line too, you know. So,
I thought you were
yeah,
talking about a central line.
yes. So, but a PIC line is a peripheral essential catheter too. So you can go home with that. You can go home with the med port, but they don't send you home with a jugular. They don't send you home with a jugular. If they're gonna give you one, it will be a subclavian that is tunneled, and it has to be tunneled. So you have to remember that when the tunnel is different from when you're non-tunneled, because if they're not tunneled, it can cause problems. They shift and they bleed into the systemic area. What else?
Blood specimens can be collected easily.
Yes. One more. Any more?
You can give more caustic material like TPN.
Yes, you do that. So what if? How long does that? How long? Yeah, those are the things. How long does oh yeah, this I need to ask you this because I'm not sure if everybody knows it. When you're given a when you're placing a central venous catheter, what position do you put the patient in?
Reverse Trendelenburg.
I'm sorry.
Trendelenburg?
Kiyomi, what do you say? I saw your thing flashing. What did you say, Kiyomi?
Trendelenburg?
Yeah, you put them in a Trendelenburg, not a reverse Trendelenburg. You put them in a Trendelenburg position when you're going to do it because you have to put them down. That's
Or supine, like, right, or sideline.
no,
We were taught two things.
okay, what were you taught?
I'm pretty sure supine and then the
So why would you put them in a supine? I'm not sure. Sorry. Did they tell you?
I just
did
know
they
that
tell you
there's
why?
two different positions that we learned, so.
Oh, okay. Well, the two positions that you learned is the supine and the Trendelenburg. Oh.
Don't you
Or
put
is
it
it
in Trendelenburg to get the blood like up there so that it's like easier to place? Like so that the blood flows upward?
Yes, but the supine, why you guys learn the supine too? So I'm not certain which are you which one which central line are you putting in when you put them in the supine? Which one?
I have no idea. And I just know that we learned two different positions.
Oh, okay. I don't know.
Yeah, I don't know.
Oh, I'm sorry. I know. I'm sorry if I know I didn't tell you that, but maybe in a different class they could have been put it, there. But usually I don't. For a central catheter, they don't put you in the supine. But if someone says that, it may have been something changed. You know what I mean? Something could have changed during the time when we taught it. So I could research that and see. But for this purpose, it's a Trendelenburg. Okay, because I have to in this class in this class that told you. And Kayla,
I don't remember when we were told. I'm trying to look it up. I just know that there was two different ones.
Because I want to know, because I want to clarify it for you. I don't want you to go with the wrong impression, because if it's not correct, I don't want you to go with the incorrect thing. Or if it's correct, I want you to know that it's correct. So
I was never put in a Trendelenburg position, and I've had like 4 of them. They just had me laying flat, and then like on the opposite side, maybe of the arm that they were going in. But I was never in a Trendelenburg per se.
I'm looking for a med-surg book, and it says place the client in supine or Trendelenburg position.
Yeah.
It doesn't give a rationale.
Right, and that's there it is. So you saw it it's in a book. So it's not that you're incorrect. It's just that we need to know where. And you never this one here and this here says if a nurse is giving it, so they They don't have supine on here either. So you wouldn't get it incorrect if you put the other one. You wouldn't get it incorrect because supine is not there. So you would not get it correct. But I know you think it's the reason why I wanted to clarify it also too is there's a position there that you use for peripheral line, and I don't want you to get that one incorrect. You may mix it up. Not you per se, but someone could mix it up that they put it in a, that position and it's not. So, because it's only for peripheral IV, they will put that position. So somebody may be reading it and read it incorrectly, and so that's it. But yeah, that's good for the clarification. Thank you there for looking that up. Then I mean, when you're doing anything, you have a lot of different ways to put things, and I'm glad that you know. But it's not, supine is not here, so I'm glad you will not get that incorrect. That's why I make sure.
So you're saying for purposes of this exam, we only use Trendelenburg. Is that what you're saying?
Yes, yes. I mean, when the person wrote the exam, it may have been that is what that was the answer. And I mean, it's the best answer, for that question.
Yeah, and everywhere else it says Trendelenburg because when you put them downwards, their jugular veins start distending.
Distending, yes. Yeah. Oh, yeah. And that has been going on for years. And supine is they put your supine, but which side, and they usually not want to put the supine because of the pressure on that and one side. It's a long story. I don't want to really get into it, but yes, there's some contraindications with the supine. So I know the prone and stuff like that it's okay. I'm just making sure everything is there that you to cover. Okay, small catheters. I think I went over the small catheter. You have to be careful when you're doing it because small people will say, well, I like to put a large one in, but small catheters have advantages. And because the big ones are painful for the patient. You're painful, and they cause discomfort after you put it in. Although it's in the arm, sometimes the patient complains that it hurts, and when patient complains that it hurts, we take it for granted, but it really hurts them. So and they want it out. Sometimes I used to think, why would you want an IV out for somebody to put another one in? But the patient said it really hurts, and they tell you, and I said so many people cannot be telling something that is not true. Yes, if you ask the patients, they say, especially when you have large catheters, when the patient goes to surgery, they put the big ones in, like the 14 and the 16, when you're asleep. And when they wake up, it's so uncomfortable for them. So the big ones cause problems like the 16 and the 14 and sometimes the 18. And when they put the small one in, the small catheters, your risk of mechanical phlebitis is get less and less, so which is a good thing. So small catheters have their advantages. Any other question? When you were taught to put in IVs, did they teach you a method, a one-hand or a two-hand method? How did they teach you? What did they call it? One-handed or two-handed method? Anybody remember?
In the beginning, it was one.
Okay, one-handed method. What?
And then I think it was when you came in, you taught me the two method, which like I could use the tape to stabilize, so I didn't have to use the one-hand method.
Yeah, they have both. They have one-handed and a two-handed, and both of them are accepted. Mm-hmm.
Yeah, I was gonna say you taught me how to put in an IV. I hadn't learned before then.
Yeah, they have the one-handed and the two-handed. Yes. So if you see one-handed and two-handed, yes, they're accepted. So one-handed and two-handed are accepted. Good. But I just want to make sure because some people.
Can you clarify that? I mean, when I put the needle in one hand and I hold the vein with the other hand. So what's one-handed?
When I'm sorry, I don't get you. I'm Steve.
I don't
I'm
understand.
Sorry.
I mean, I always called it two-handed because you're inserting the catheter with your right hand if you're
Yes.
right hand dominant, and you hold the vessel with your left thumb. So
Yes.
what's one-handed?
When you have one hand, you do everything with your one hand. Yes, you can do that
So
too.
you're stabilizing the vessel. How can you stabilize the vessel and use the catheter at the
Okay,
same
so
time?
right, I'm Stephen. I'll show it to you another time. Right now, it's not
Okay,
important
thank you.
right now.
All right,
Yeah,
no
it's
problem.
not important right now, so I don't want you to go into that. Yeah. But you cannot go wrong. It's one-handed and two-handed, and that's how we do it. So you don't have to worry about that. And okay, when you're given an IV and you're sticking this patient, what area of the skin are you do you puncture first? What area of the skin do you puncture first? What area of the skin do you puncture first?
The epidermis, the outer layer of the epidermis.
Okay, anybody else? You have several layers, right? Name the layers. You have, and it's called tunica, right? So you have the tunica. You have you said epidermia. What else? What's the other area? You have the media. What's the other area? You have the intima, and you have the adventitia, right? And it's not the epidermis. Epidermis is not the first area. The first area you do is the adventitia. So remember that. Not the epidermis. It's not.
That's
The
the
tunica,
outer-
the tunica,
the about the
tunica
vessel.
adventitia is the area you get first when you stick the patient.
That's
The
through the
yeah.
vessel, not through the skin. You're talking about the blood vessel layers.
Yes, I'm talking about the blood vessel. So when you go through the skin, I said when you go through the skin, which layer of the vein would you catch first?
Okay, that clarifies. Thank you.
Okay, dear. Any other questions?
Is everything we need to know for the exam in that PowerPoint?
Yes. And the PowerPoint you had before.
Would you mind posting it for us?
Okay, so if you have fluid, which fluids are caustic? Are you talking about is sodium bicarb caustic? Yes, it is. Is dilantin caustic?
Yeah.
Okay. Is potassium chloride caustic? Yes, it's one of the most caustic medication you'll ever give. Remember that. You can never forget that. I've never nursed a patient and the potassium chloride don't burn them. Never, ever. On all my years of nursing. Always. You'll
That's
never
right.
find a patient it doesn't burn.
That's
if it
why
doesn't burn them. Huh?
Sorry, Dr. Halen, I'll wait till you're finished. I apologize.
No, and then vancomycin is also caustic. And I've said that several times. So vancomycin, sodium bicarb, dilantin, which is phenytoin, is caustic. Sodium chloride, not sodium chloride, potassium chloride, vancomycin, and sodium bicarb. Yeah, sorry. Go ahead, Ms. Melissa.
Oh, I was just going to say that's why you can't push potassium, right?
You don't know, and also you don't push it because of the heart.
Because of the arrhythmias?
Yes, it
Okay.
causes arrhythmia and dysrhythmia, both of them.
Thank you, ma'am.
No rhythm, and then the other mess up your rhythm. Yes, there. So make sure you were writing because I'm not going to post this phlebitis. Any other question? What
study? Like what information should we review?
Everything that is on everything that is on this, everything that is on the monitor, everything that is on this, everything that is there.
But you said you're not posting the PowerPoint?
Yeah, I'm gonna post it later, not right now, because I'm gonna do another class.
Okay.
But I post but yeah, everything that is there, everything that is on the PowerPoint is gonna be on your test. Everything. And I mean, I didn't put any dosage calculation, because you have had that already, and I know I don't want to overwhelm you with dosage calculation. You guys know that all of you do good in dosage calculation too, so I won't overwhelm you with that.
That was one question I did have. You said know your heparin calculations. Is it
Yes.
like something different that we're?
I'm sorry?
Is heparin like something different specifically for dosage calc?
Oh no, it's not different. It's just
Okay.
you have had dosage calculation about heparin, right?
Yeah, it'll usually
Yeah,
just
it's not different. It'll say the heparin one, because you know somebody's going to say, okay, nobody told me about the heparin. Yes, heparin. You know, you give somebody heparin daily and you calculate it.
Is that like the sliding scale that you mean for heparin? Do you want us to review the sliding scale for the?
No, not a sliding scale. If you give it, okay, right. What if you're giving a patient heparin like 5,000 units and you read it, you read the label, or the label said 10,000 units in an ml, and you're reading the label and they said give a certain amount. You know how much ml to give, right?
Right.
Yes.
Yes.
If you're giving the dopamine and the dopamine says 3 milligrams per kilograms per minute, you know, you know that, because this said everybody, all the classes you guys have had, you did very well in dosage calculation, so I didn't have to go over that one. Okay, that's what you guys, that's what it says. So I know you guys are good at that one, so I didn't have to go over it. But everything that is on this, like the nursing management is not something you guys don't need to know the nursing management of, but you need to know everything that I went through on this is going to be there. Everything that is there. And you guys had another PowerPoint, right? So before this? Huh?
Yes, the one that you posted at the beginning of the semester.
Yes. Everything. I mean, I went over. I went over every one of the questions on here. Every one of them. Every one.
Just to clarify, the exam's next Tuesday at 2 p.m. on campus, and we should bring
No,
our iPads.
2 p.m. on campus. Yeah, because in the morning usually 9 a.m. but in the morning you guys have a class, so it's going to be 2 p.m. They usually do it in the morning when they have midterm, but it's 2 p.m.
So after the exam, are we finished after that, or are we staying
No.
till 6?
You stay until 6.
We stay until 6.
Yeah, because it's your hours, it's clinical hours, so we can't short clinical hours. That's the way the problem comes in clinical hours. And students, they're not fussy about not the students, but State Board of Nursing is not fussy about the lecture hours, but the other one they're fussy about.
Of course, thank you so much.
Yeah. All right, guys. So I have to go through. I have to do 1 or 2, 3 to 4. Sorry.
Thank you so much.
Okay. Thank you, dear.
Thank
Thank
you.
you so much for that review. We appreciate it.
I'll put that in. Give me a minute. I'll put it in after I'm done with this class. Okay.
All right. Thank you, Dr. Haylett.
Thank you. Bye bye.
Have a good night.
Have a good night.